Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. So in this session, I'll be discussing the previous year questions in UPSC related to the topic of the endocrinology, and I'll be discussing in detail about that individual topics which will be useful for your upcoming UPSC exams. So the first question is, which of the following is the most common dermatological manifestation of the diabetes mellitus? The options are xerosis, acanthosis nigricans, lichen planus, and necrobiosis lipoidica diabeticorum. So you take the complications in diabetes mellitus, like we have the microvascular complications and macrovascular complications and avascular complications. So these are the chronic complications, micro, macro, and as well as the avascular complications. And we have the acute complications in diabetes mellitus, that is diabetic ketoacidosis and as well as the hyperosmolar non-ketotic coma, right? Now, what are the various dermatological manifestations? So the most common dermatological manifestation is the non-healing ulcer, right? Non-healing ulcer. And this non-healing ulcer, it is observed over the sole of the foot, right? So it is observed over the sole of the foot, okay? Then followed by that, the next most common dermatological complication will be acanthosis nigricans, right? So it will be the acanthosis nigricans. So acanthosis nigricans, it is the hyperpigmentation of the back of the neck, right? So it is the hyperpigmentation of the back of the neck, right? And the extensor aspect. And this acanthosis nigricans is also observed in case of the polycystic ovarian disease. Next, in case of carcinoma of the pancreas and the carcinoma of the colon, right? So these are all the conditions where you have the acanthosis nigricans. And that is the next important dermatological complications in diabetes mellitus. Next is necrobiosis lipoidica diabeticorum. Necrobiosis lipoidica diabeticorum, right? So this is observed over the shin of the tibia. And this necrobiosis lipoidica diabeticorum, this is commonly observed over, this is commonly seen in females rather than males, right? And the differential diagnosis of the necrobiosis lipoidica diabeticorum, it is martoral ulcer which is seen over the shin. And this martoral ulcer which is observed over the shin, it is seen in atherosclerosis, right? So this is due to atherosclerosis, right? So that is about the necrobiosis lipoidica diabeticorum. Now, so among these options, like which is the most common dermatological complications, that is the acanthosis nigricans. Let me show you these images, right? So this is the acanthosis nigricans, where it is being described as the hyperpigmented skin or the dark velvety skin, right? And this is the image of necrobiosis lipoidica diabeticorum, which is commonly observed over the lower limbs. And how is this appearance? The appearance is orange yellow in color, right? And they will be having the central clearing, right? They will be having the central clearing. So this will be the dermatological complication, right? Then, now what are all the various avascular complications observed in diabetes mellitus? One is the dermatological complication that just now I have discussed, that is necrobiosis lipoidica diabeticorum, acanthosis nigricans, and as well as the non-healing ulcers. And the other avascular complications are the development of cataract. Next is glaucoma, right? And diabetic amyotrophy. So diabetic amyotrophy is that where the individual will have the proximal muscle weakness. Right, so diabetic amyotrophy is that where the individual will have the presence of the proximal muscle weakness. Alright, this is what is called diabetic amyotrophy. Then coming to the vascular complications, we classify these vascular complications into two. One is the microvascular complications, then macrovascular complications. Right, then macrovascular complications. Now, what are the examples of the microvascular complications? The examples of the microvascular complications include diabetic retinopathy, then diabetic neuropathy, then diabetic nephropathy. Alright, so these are the microvascular complications, whereas if you take the macrovascular complications, that includes coronary artery disease, cerebrovascular accidents, and peripheral arterial disease. So these are the macrovascular complications. Now, if you take the description related to, and one more important, the avascular complication will be infections. These individuals, they are more prone for the infections. And what are these infections very commonly observed in diabetic patients are the fungal infections. And these fungal infections, they include rhinocerebral mucormycosis, right? That includes the rhinocerebral mucormycosis. So in case of this rhinocerebral mucormycosis, these patients, they have the involvement of the frontal lobe. Right, so these patients, they have the involvement of the frontal lobe. Okay, and because of this, the patients will have the clinical features like aggressiveness and antisocial behavior. Right, aggressiveness and antisocial behavior. And in case of rhinocerebral mucormycosis, on examination, you will notice the presence of black nasal discharge. Right, black nasal discharge. That is what you will observe on the nasal speculum examination also. So on examination with the nasal speculum, right, so on examination with the nasal speculum, you will notice the presence of a black fungal mass. Right, you will notice the presence of the black fungal mass, and that too bilateral. Okay, then what will be the drug of choice in case of the rhinocerebral mucormycosis? The drug of choice will be amphotericin B. Right, the drug of choice will be amphotericin B. So this will be the treatment for rhinocerebral mucormycosis. And another important infection which is very common in diabetic individuals are the Aspergillus niger. Right, the Aspergillus niger. So this is also an angioinvasive structure. Okay, these are the avascular complications. Now coming to quick discussion related to the microvascular complications. This diabetic retinopathy, we have two forms. Right, one is the proliferative diabetic retinopathy, then non-proliferative diabetic retinopathy. So in case of proliferative diabetic retinopathy, what is the earliest manifestation is the presence or the development of the microaneurysms. Right, microaneurysms. Okay, now in proliferative diabetic retinopathy, there can be blindness. What is the cause of the blindness? That is due to retinal detachment. Right, so retinal detachment will be the cause of blindness in case of the proliferative diabetic retinopathy. Then how do you treat this proliferative diabetic retinopathy is by injection of intravitreal, right, intravitreal bevacizumab, right, intravitreal bevacizumab, or you can also do ND-YAG laser, right? So you can also do ND-YAG laser. So this is a treatment for the proliferative diabetic retinopathy. Whereas you take in case of the non-proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy, what is the cause of blindness in this individual is, the cause of blindness in this individual is the macular edema. And what is the treatment that you need to give in case of non-proliferative diabetic retinopathy is, the mainstay of treatment is the control of the blood sugars. That will be the treatment in case of the non-proliferative diabetic retinopathy, right? Now, so that was the story related to diabetic retinopathy. Then coming to the diabetic nephropathy. So if you take this diabetic nephropathy, this is very common in type 1 diabetic patients then compared to that of the type 2 diabetic patients, right? And what will be the manifestations in diabetic nephropathy is, initially there will be hyperfiltration, right? So in the sense, there will be increase in the GFR in the early stages, followed by that there will be proteinuria. So initially it will be like microalbuminuria, where the quantity of the protein which is being excreted out is 30 to 300 milligrams per gram of the creatinine being excreted out. And subsequently, the individual will progress to the development of the end stage renal disease. Okay, so this will be the progression in case of the diabetic nephropathy. Now, in diabetic nephropathy, these patients, what is the pathological change which will be seen in early stages? So the pathological change that you will observe is diffuse thickening of the glomerular basement membrane, right? Diffuse thickening of the glomerular basement membrane. And when you take these glomerular lesions, the glomerular lesions that you will observe in diabetic nephropathy will be diffuse glomerulosclerosis, and then nodular glomerulosclerosis. Right? But between these two, which is more common? The nodular glomerulosclerosis, between these two, it is the diffuse glomerulosclerosis which is more common. And in diffuse glomerulosclerosis, you will notice diffuse thickening of the glomerular basement membrane. And in nodular glomerulosclerosis, they are considered as the pathognomic of diabetic nephropathy, right? Pathognomic of diabetic nephropathy. And this nodular glomerulosclerosis, the lesions that you will have is the KW lesions, right, which are called as the 𝐒𝐿-Steele-Wilson's lesions, right, which are called as the 𝐒𝐿-Steele-Wilson's lesions. Then what exactly is the drug of choice in patients with diabetic nephropathy? The drug of choice will be the AC inhibitors, right, or you need to give angiotensin receptor blockers, right? And as the time progresses, once the individual goes into a state of end stage renal disease, that is the point when you need to do the dialysis, right? That is the point when you need to do dialysis, or you need to plan for the kidney transplantation, right? And all the diabetics, they should be screened for the proteinuria, right? All the diabetics, they should be screened for proteinuria annually, right? So in order to have the early detection of the proteinuria. And so initially what they will have is the microalbuminuria, and the quantity of the microalbuminuria, it is around 30 to 300 milligrams per gram of the creatinine which is being excreted out. Okay, and what is the purpose of giving ACE inhibitors? The ACE inhibitors will reduce the intraglomerular pressure, and thereby they will reduce the proteinuria, right? So that is about the diabetic nephropathy. Then the next important complication, a microvascular complication, will be diabetic neuropathy, right? So if you take this diabetic but first of all, you need to remember and understand that all these microvascular complications, they are completely dependent upon the HbA1c. If the HbA1c is more than 7%, then the chances of microvascular complications are very high, right? And if you take this diabetic neuropathy, in diabetic neuropathy, all the sensations are getting affected. Sensory sensations, motor sensations, and autonomic sensations. But the sensations which are affected first, that will be the sensory sensations. Followed by that, there will be motor manifestations. Followed by that, you have the autonomic involvement. Right? So sensory, motor, and as well as the autonomic involvement. But the one which is affected first will be the sensory sensations, right? And the sensory sensations are the one which are lost first. And among the sensory sensation, the one which is being lost first is the vibration sense. Right? Vibration sense is being lost first, right? And this vibration sense which is being lost first, that is measured with the help of a tuning fork of 128 Hz, right? And this particular diabetic neuropathy, it is a small fiber neuropathy. And if you take the motor neuropathy, you have the development of mononeuritis multiplex, right? Where there can be carpal tunnel syndrome. And even you have the cranial nerve involvement. The cranial nerves which are affected first will be the third cranial nerve. Third cranial nerve is the one which is affected first, right? Then followed by that, you have the involvement of the seventh nerve. So even though there is third cranial nerve involvement here, these patients, they will have the pupillary sparing, right? These patients, they will have the pupillary sparing, right? And as a part of the neuropathy, they will also have the autonomic neuropathy, right? Now, in the part of the autonomic neuropathy, these patients, they develop the orthostatic hypotension, right? So they develop orthostatic hypotension, okay? So orthostatic hypotension is that where the systolic blood pressure, right? Where systolic blood pressure, it will fall by more than 20 millimeters of mercury upon standing, and diastolic blood pressure, it will fall more than 10 millimeters of mercury upon standing. So this is what is your orthostatic hypotension, and that is because of your autonomic neuropathy, right? And these individuals, they will also have the gastroparesis. There can be constipation or there can be even diarrhea also. And these patients with a diabetic autonomic neuropathy, they will also have silent MI. They will not have the Levine sign. So Levine sign will be absent. What do you understand by this Levine sign? Levine sign is that where the individual will clutch the fist over the precordium while describing the chest pain. That is what is called Levine sign. The individual will not have the chest pain, so the Levine sign will be absent in these patients, okay? And what is the diagnostic test for this autonomic gastropathy? That is for gastroparesis. For gastroparesis, the diagnostic test of choice is gastric emptying scintigraphy study. So that is about your diabetic neuropathy. And because of diabetic neuropathy, that is autonomic neuropathy, these patients will also have the erectile dysfunction, right? For which, like, you need to give the phosphodiesterase inhibitors, right? So that was about, and one more point is sensory neuropathy. These patients, they'll have tingling and numbness over the extremities, or they'll also have dysesthesias like burning sensation. So what is the drug that you need to give in these patients is, you need to give duloxetine. So duloxetine, this is considered as the drug of choice for peripheral neuropathy. And apart from duloxetine, the other drugs that can be given in these individuals will be like gabapentin can be given, right? Or the pregabalin can be given, right? Or the tricyclic antidepressants can be given. So this will be the treatment for your peripheral neuropathy. So this is the microvascular complications, retinopathy, neuropathy, and as well as the nephropathy in diabetes mellitus. Then coming on to the next question, which one of the following condition may result in the hypoglycemia? The critical illness, cortisol therapy, Cushing's disease, metabolic syndrome. Now, the hypoglycemia, it is observed in case of the critical illness. So the examples of the critical illness include like sepsis, right? Or the patient having the liver failure, right? Or the patient having the renal failure. So in case of the critical illness, so in case of sepsis, why there will be hypoglycemia? Because the organisms which are like excessively growing in the sepsis, they will utilize the glucose resulting in hypoglycemia. Then you take liver failure, so there will be no hepatic gluconeogenesis and that will result in hypoglycemia. And you take in case of the renal failure, the insulin is not excreted out, the excess insulin which is elevated in the body will cause the hypoglycemia, right? So critical illness, this can lead to hypoglycemia due to increased metabolic demand. Right, so due to increased metabolic demand. Right, so that is about the story related to critical illness. Then you take in all the other conditions. See, cortisol therapy and Cushing's syndrome, in both of them they will have the hyperglycemia. See, what exactly is the cortisol? Right, so cortisol, even in case of the Cushing's disease, so what exactly happens in Cushing's disease? In Cushing's disease, there is increase in the cortisol levels, and this increased cortisol in Cushing's will increase the hepatic gluconeogenesis. So once there is increase in hepatic gluconeogenesis, the non-carbohydrate moiety is converted into glucose. So the glucose levels are increased in case of the Cushing's disease, right? And even you take in case of the metabolic syndrome. In metabolic syndrome, one of the very important component is the abdominal girth will be increased. Okay, that is abdominal circumference. I mean to say the abdominal circumference will be increased, and these patients will have the dyslipidemia, and they will also have the hyperglycemia. Right, so they will also have the hyperglycemia, and they will have abnormality within the blood pressure. Okay, so the hyperglycemia is a part of the metabolic syndrome, which is also called the syndrome X. Now you take this hypoglycemia in a diabetic patients, right? If at all, if there is hypoglycemia, what could be the reason in a diabetic patient? If the patient has taken excess amount of insulin but inadequate diet, that can cause the hypoglycemia, right? Or the patient has taken oral hypoglycemic agents but he did not take adequate amount of diet, then that can cause hypoglycemia. And hypoglycemia, it could be due to certain neuroendocrine tumors like the insulinoma. Even insulinoma can contribute to the development of the hypoglycemia. How will you differentiate that? So, whenever there is hypoglycemia, right, check the insulin level. Okay, so if you find that there is increase in the insulin level, two reasons. Either it should be an exogenous insulin or the insulin which is being produced in excess quantity within the body from insulinoma. So immediately what you need to do is you need to check for the C-peptide levels. If you find that the C-peptide levels are also elevated, then it is hypoglycemia due to increase in the endogenous insulin. Right? Hypoglycemia due to increase in the endogenous insulin. And that is what is nothing but your insulinoma. Right? So insulinoma, oral hypoglycemic injections, which one? Mainly the sulfonylurea. So sulfonylureas, they are the one which will stimulate the beta cells to produce the insulin. And along with the insulin, even there will be release of the C-peptide levels as well. Okay. So whenever the C-peptide levels are elevated, please remember either it should be an insulinoma producing excess amount of insulin, or the ingestion of the sulfonylurea where there will be increase in C-peptide levels. But if you find that the insulin levels are increased but the C-peptide levels, they are either reduced or they are remaining normal, then in such case you need to consider exogenous insulin, because exogenous insulin does not contain the C-peptide. So that is the reason why, like if the C-peptide levels are reduced or if they are remaining normal, then you need to consider it as exogenous insulin. So that is how you need to evaluate the cause of the hypoglycemia, right? So that was about the second question. Yeah, third question is related to the oral hypoglycemic agents. See, the topics which have been concentrated most in the UPSC exam, diabetes mellitus. Everything related to diabetes mellitus, the questions have been asked previously based on the types of diabetes mellitus, based on the diagnosis, based on various drugs, based on the types of insulins, based on the complications related to diabetes mellitus. So the entire topic of diabetes mellitus is very, very important from the UPSC exam point of view, right? So the question is, which one of the following oral anti-diabetic drugs, they act on renal proximal tubules? The options are alpha glucosidase inhibitors, GLP-1 analogs, DPP4 inhibitors, then the SGLT2 inhibitors. So the drugs which will be acting on the proximal tubules will be the SGLT2 inhibitors. What these SGLT2 inhibitors will do is, the SGLT2 inhibitors will prevent the glucose absorption, right, or they will inhibit, right, they will inhibit the glucose absorption from the proximal convoluted tubule, and thereby these SGLT2 inhibitors, they cause the glucosuria, right? So thereby what will happen to the quantity of the glucose in the urine? It is increased, and thereby these individuals, the very important adverse effect is they are at increased risk of the urinary tract infection. And what are the examples of this SGLT2 inhibitors? Examples include dapagliflozin, then empagliflozin, right, dapagliflozin and as well as the empagliflozin, right? So this is about the examples of the SGLT2 inhibitors. Now, what about the other drugs? The alpha glucosidase inhibitors, they act in the level of the GIT, right? So they mainly reduce the postprandial blood glucose, right? They mainly reduce the postprandial blood glucose. What these drugs will do, they will inhibit this enzyme alpha glucosidase, right? So they will inhibit this enzyme alpha glucosidase. Now, by inhibiting this particular enzyme alpha glucosidase, what happens is, normally what should happen in the GIT, the complex carbohydrates, they get converted to the simple carbohydrates, right? They get converted to the simple carbohydrates, okay? Now, this complex carbohydrates, they get absorbed only when they get converted into simple carbohydrate by the enzyme, the alpha glucosidase. Now, if this alpha glucosidase enzyme is inhibited, the complex carbohydrate is not converted into simple carbohydrate, so they are not being absorbed and they get excreted within the feces. And what will be the adverse effect of these alpha glucosidase inhibitors are, the important adverse effect that includes the flatulence, right? The important adverse effect that includes the flatulence. Why? Because the complex carbohydrates which are not digested, they get fermented by the gut flora, right? So they get fermented by the gut flora, okay? So because of the fermentation by the gut flora, there will be excess amount of the gases which are produced within the gut lumen, and that will result in the development of the flatulence. So that is about the story of the alpha glucosidase inhibitors. Then GLP-1 analogs and as well as DPP4 inhibitors. GLP-1 analogs and as well as so what are the examples of these alpha glucosidase inhibitors? The examples of the alpha glucosidase inhibitors, they include acarbose, and the next important molecule is the voglibose, right? Next important molecule is the voglibose. Then you take the examples of the GLP-1 analogs. Examples of the GLP-1 analogs, they include liraglutide and as well as the exenatide. Now, what this liraglutide and as well as the exenatide does? First of all, what is the route of administration of this drug? The route of administration of this liraglutide or exenatide, it is subcutaneous, right? And this GLP-1 analogs, what they do is they decrease the levels of the glucagon and they increase the levels of the insulin. Okay, that is what the GLP-1 analogs does. And the next important group of examples are DPP4 inhibitors. Examples of DPP4 inhibitors, they are gliptins. And the examples of the gliptins, they include like sitagliptin, vildagliptin, saxagliptin, right? And so these are the examples of the gliptins, that is DPP4 inhibitors. And these gliptins, what they do is the same like what is the action of the GLP-1 analogs, because DPP-4 inhibitors, what they do ultimately, DPP-4 inhibitors, they increase the levels of the GLP-1. Okay, because your DPP-4 enzyme, that is dipeptidyl peptidase 4 enzyme, is the one which will metabolize the GLP-1. And if DPP-4 enzyme is inhibited, what will happen to the GLP-1 levels? There will be increase in the GLP-1 levels. Okay, and this increase in GLP-1 levels, what they do is they decrease the glucagon and they increase the insulin levels. Okay, so that is about the effect of the DPP-4 inhibitors. And thereby what will happen, once they increase the insulin levels, they will reduce the glucose. Okay, and once they decrease the glucagon, the gluconeogenesis will be reduced. Okay, so that is the effect of the insulin and as well as the glucagon, right? So examples are the gliptins. So these are all the various oral hypoglycemic agents except for your GLP-1 analogs which are given through subcutaneous route. Then what are the other examples of the anti-diabetic medications? We have the sulfonylureas, first generation and second generation. And these sulfonylureas are also insulin secretagogues. They stimulate the beta cells and thereby they produce the insulin. First generation sulfonylureas, they are not being used these days because they are prone for excess amount of hypoglycemia. Example like chlorpropamide and as well as the tolbutamide. It is the second generation sulfonylureas which are very commonly used these days. That includes the glibenclamide, glimepiride, glipizide, gliclazide and gliburide. So these are the examples of the second generation sulfonylureas. So what these second generation the sulfonylureas do? They increase the insulin secretion. And the important adverse effect is the development of the hypoglycemia because they stimulate the release of the insulin and they reduce the blood glucose levels. And the next important is because of the repeated hypoglycemia, the individual will be consuming excess amount of the carbohydrate and that can cause the weight gain within the individual. So that is about the sulfonylureas. Then you take the bigonides. The examples, see actually bigonide, that is metformin, this is considered as the drug of choice in case of the type 2 diabetes mellitus. And it is an insulin sensitizer. And the advantage of the metformin is that it is the drug which will cause the maximum reduction in the HbA1c. So this will reduce the HbA1c by almost 2%, right? And that is the reason why it is considered as drug of choice. And this metformin will never cause hypoglycemia, and the added advantage of the metformin is it will also cause the weight loss, right? So this will also cause the weight loss, okay? And this particular metformin, the adverse effect include the development of lactic acidosis, right? Lactic acidosis, and it will also cause gastritis, that is gastrointestinal disturbances. That is the reason why metformin is usually being prescribed after the food. So that is about the bigonide, that is metformin. Then the alpha glucosidase inhibitors, just now we were discussing, that is acarbose and as well as the oglibose, and they will delay the carbohydrate digestion. Then next, like what we have is thiazolidone diones. Examples of these thiazolidone diones will be the pioglitazone and as well as the rosiglitazone. And this thiazolidone diones, they will stimulate an important molecule within the nucleus, and that is called PPAR gamma, right? So what these thiazolidone diones will do, they improve the insulin sensitivity, right? They will improve the insulin sensitivity, right? And the other group of drugs are glinides, rapaglinide and nataglinide. These are not used these days, and these are considered as new molecules, that is incretins, GLP-1 analogs. That is what I have discussed, that is exenatide and as well as liraglutide. So what they will do, they will enhance the insulin secretion and it will suppress the glucagon secretion. The same mechanism is being done even by your DPP-4 inhibitors as well. Then we have another important molecule called amylin analog, that is pramlintide. So amylin is a substance which is being produced along with the insulin from the beta cells. And this amylin analog pramlintide, it is used in the treatment of both, that is type 1 and as well as the type 2 diabetes mellitus. And the route of administration of this amylin analog is also the subcutaneous. And what is the mechanism of action? It increases the absorption of the glucose by slowing the gastric emptying, right? And it will also promote the satiety. So that is what is the effect of the amylin analogs, right? Then, yeah, next is the combination drugs. So this is about the group of drugs, right? The group of various drugs that we give in the treatment of the type 2 diabetes mellitus. Okay, now we'll move on to the next question. Yeah, so this is the question Right. So this is the question on the topic of the insulin. So the previous question was on the oral hypoglycemic agents. Which of the following are the short-acting insulin? Aspart, Lispro, Glargine, and the regular insulin. Select the correct answer using the code given below. So among this, your Aspart, it is the short-acting insulin. Lispro is also a short-acting insulin. Then the regular insulin is also a short-acting insulin, whereas Glargine, this is the long-acting insulin. Okay. Now, if the answer will be what? That is 1, 2, and as well as 4. Now, if you see the classification of the insulin preparation, the classification of the insulin preparation is as follows. That includes, we have the ultra short acting insulin, that is insulin Lispro and Aspart. Next, rapid acting insulin, that is regular and as well as the semi-lente. Intermediate acting insulin, that is NPH and as well as the lente. And long acting insulin, that includes Glargine and as well as the Levemir. So these are the types of insulin, out of which long acting insulin, they act for nearly around 24 to 36 hours. And we have one more important longest acting insulin, that will be insulin degludec. And this insulin degludec, this will act for nearly around 48 hours. This will act for nearly around 48 hours. Okay. Then and if you take this NPH insulin, which is an intermediate acting insulin, this will be acting for nearly around 12 to 18 hours. Whereas the short acting insulin like regular insulin will act around 6 to 8 hours. Then what is the ideal insulin supplementation in an individual is, you need to give 3 short acting, right? So you need to give 3 short acting plus 1 long acting insulin. Okay, so these 3 short acting insulin doses, that will be useful mainly to control the glucose of breakfast, lunch and dinner. These are 3 boluses. Whereas long acting insulin is the one which will give the basal insulin and which will control the glucose throughout the day. Right? That is the long acting insulin. So these are all the various insulin preparations. And you have to remember that the route of administration of the insulin is subcutaneous. And what is the preferred site? The preferred site of the insulin administration will be over the abdominal wall. And why is that we need to give over the abdominal? See, it is exactly 2 centimeters away from the umbilicus. Right? So this is exactly 2 centimeters away from the umbilicus. Okay. And why is that we are giving over the umbilicus? Means because it has the fastest absorption. Then what are the other sites where you can supplement the insulin? Over the arm, over the anterolateral aspect of the thigh, over the buttocks. But please remember, the insulin should not be administered over the dorsum of the hand, because you don't have the subcutaneous fat there, right? So the route of administration will be subcutaneous, right? And we also give the IV insulin. But in which scenario we give IV insulin is in case of complications like diabetic ketoacidosis and as well as the hyperosmolar non-ketotic coma, we give the intravenous insulin infusion. And if you take the various modes of the insulin delivery, the best method of the insulin delivery is the insulin pump. And this insulin pump, right, it is a microprocessor device, and this will be acting as an artificial pancreas. Right, so this will be acting as the artificial pancreas. Okay, so this insulin pump, it will give you both. So it will give you the basal insulin, right, and this will also give you the bolus insulin. Right, it will give you both basal and as well as the bolus insulin. Okay, that is the insulin pump. Then next is the insulin pen. So in case of the insulin pen, the needle that we use is the 31 gauge needle. Right, why is that we are using this 31 gauge needle? Because this particular needle, it is painless and as well as the bloodless. right, as well as the bloodless. So that is the reason why we use 31 gauge needle. And we also previously we were using inhalation insulins, examples Alfreza, and the other one is the Exubera. But both of these insulins, that is Alfreza and as well as Exubera, they are outdated. They are not being used these days because of associated pulmonary adverse effects. Then we have the multi-dose vial and as well as the syringe. So these are the methods of the insulin delivery. And if you take the complications associated with the insulin usage, one of the very important complication is the hypoglycemia. Because if the insulin which is being taken is more and the diet which is taken is not adequate, that can cause the hypoglycemia, right? And the other important complications with insulin usage is the early morning hyperglycemia. Now, what are the various causes of the early morning hyperglycemia? I will discuss that. Right, so if you see this question, early morning hyperglycemia with increased glucose of 3 a.m. suggest insufficient insulin, Donn's phenomena, 𝐒𝐿 effect, none of the above. So now it is early morning hyperglycemia, and along with that there is increased blood glucose level even at 3 a.m. also. Now let me discuss the various causes of the early morning hyperglycemia. The various causes of the early morning hyperglycemia is: number 1, fasting hyperglycemia. Number 2, Donn phenomena. Number 3, 𝐒𝐿 effect. Right, number 3, 𝐒𝐿 effect. Okay, then what are the causes in this? You take fasting hyperglycemia. The cause of the fasting hyperglycemia is due to reduced night dose of the insulin. Right, so like what is that? See, the patient has been advised to take 20 units in the night, for example I am telling, but patient has taken only 10 units instead of 20 units. That will result in the fasting hyperglycemia. So how will you evaluate this? Like if you check the 3 a.m. blood glucose levels, that will be high, and even you check the 6 a.m. blood glucose levels, even that also will be high, right? Even that also will be high. So that is what is your fasting hyperglycemia, and that is due to what? Decreased night dose of insulin. So what is the treatment that you need to do here? You need to increase the night dose. Right, you need to increase the night dose, right? Then coming to the Donn phenomena. So if you take the Donn's phenomena, this is due to early morning growth hormone surge. So early morning growth hormone surge. So that is the reason why in the middle of the night at 3 a.m. they will have normal blood glucose levels. 6 a.m. blood glucose levels will be high, right? So that is what is your Donn's phenomena. Then 𝐒𝐿 effect. 𝐒𝐿 effect is due to increased night dose of the insulin, right? Where the patient has been advised 10 units, but he has taken 20 units accidentally. So what will happen to the blood glucose levels in the middle of the night? It will drop down because he has taken excess amount of dose. And in respect to this hypoglycemia, there will be release of the counter-regulatory hormones, thereby the 6 a.m. blood glucose level will be high. Then what are these counter-regulatory hormones? The counter-regulatory hormones, they include the growth hormone, they include the glucagon, right? They include the steroid, they include the catecholamines, and they include the thyroid hormone. Okay, so these are the counter-regulatory hormones, right? What these counter-regulatory hormones will do? Counter-regulatory hormones, they will increase the blood glucose levels in response to the hypoglycemia. That is the reason why at 6 a.m. these patients will have the hyperglycemia. At 6 a.m. these patients will have hyperglycemia. So this is about the causes for early morning hyperglycemia. If you go back to this question, early morning hyperglycemia with increased blood glucose of 3 a.m. right? So that means in the middle of the night also the blood glucose is high, and early morning also the blood glucose is high, and that is due to the insufficient insulin, which is nothing but the fasting hyperglycemia, right? Now you need to understand one important point here is that the insulin is the drug which we give in type 1 diabetics. Usually in type 2 diabetics, just now I have said you, we give oral hypoglycemic agents. But there are certain exceptions. There are certain exceptions where you will be giving insulin in type 2 diabetes mellitus. Okay, like for example, a patient with type 2 diabetes have developed a complication like diabetic ketoacidosis or hyperosmolar non-ketotic coma. We need to give insulin rather than OHA. Right? Pregnancy, we give insulin rather than the oral hypoglycemic agents. A patient with type 2 diabetes with OHA failure, okay, not responding to the oral hypoglycemic agents, then patient had developed an acute illness or patient is undergoing surgery, then in such case we stop the OHA and then we start the insulin, right? And the patient who has developed renal or the hepatic failure with type 2 diabetes mellitus, then we give the insulin. So these are the scenarios where we give insulin in a type 2 diabetic patients, right? So that was about the treatment of diabetes mellitus. So if you see the next question, use of which of the following drugs may result in the osteoporosis? Phenytoin, lithium, methotrexate, azathioprine. Select the correct answer using the code given below. 1, 2 and 3. Okay. Now if you take the drugs which will be causing the osteoporosis, phenytoin, yes, it will cause the osteoporosis. Lithium will cause the osteoporosis, and even the methotrexate will also cause the osteoporosis, but not the azathioprine. Phenytoin, how it will cause osteoporosis, I'll try to explain to you. You take phenytoin, it is an anticonvulsant drug, and what this phenytoin will do is it will decrease the bone mineral density and it will increase the risk of the osteoporosis. Now the question comes, how it will decrease the bone mineral density? How it will increase the risk of osteoporosis? The phenytoin, it interferes with the vitamin D metabolism, right? So this will interfere with the vitamin D metabolism, which is crucial for the calcium absorption and as well as the bone health. Now because it is interfering with the vitamin D metabolism, what will happen to the calcium levels? There will be decrease in the calcium levels, and that will increase the risk of the osteoporosis. Then coming to the lithium. So if you take the lithium, this medication, it is commonly used in bipolar disorder. This is also associated with the osteoporosis, but the intensity of the osteoporosis, it is less. Okay, so right, a small correction here. This lithium causing osteoporosis, it is very less, right? It is uncommon. So what will be the answer? I will tell you, right? Whereas methotrexate, it is an immunosuppressant drug used in the treatment of the osteoporosis, and this methotrexate will also cause the osteoporosis, right? Sorry, where is this methotrexate used? It is used in the treatment of rheumatoid arthritis, and this can contribute to bone loss and as well as the osteoporosis. And you take the azathioprine. Azathioprine, it is also an immunosuppressant drug, and this is also associated with increased risk of the osteoporosis. So what this azathioprine is, whenever you use this azathioprine for a for a long term, that will interfere with the bone metabolism, right? That will interfere with the bone metabolism. And that will increase the osteopenia, or it will decrease the bone mineral density, right? So this will decrease the bone mineral density. Okay, so the correct answer here is 1, 3 and as well as 4. And what is the endocrine disorder associated with osteoporosis is the hyperparathyroidism. So in hyperparathyroidism, there will be increased osteoclastic activity resulting in the osteoporosis. Now, if we see the quick revision of the hyperparathyroidism, the most common cause for primary hyperparathyroidism will be solitary parathyroid adenoma. Right, so this will be solitary parathyroid adenoma. Now, apart from the solitary parathyroid adenoma, what are the other etiologies that will be causing primary hyperparathyroidism? That includes parathyroid carcinoma, right? And that includes the parathyroid hyperplasia. Okay, so these are the causes for primary hyperparathyroidism. Whereas, if you take secondary causes for hyperparathyroidism, that includes the chronic renal failure, then vitamin D deficiency, then malabsorption. Right, then malabsorption. Okay, these are the secondary causes for hyperparathyroidism. Then we also have other causes for hyperparathyroidism, that includes squamous cell carcinoma of the lung, then adenocarcinoma of the kidney. Right, adenocarcinoma of the kidney. These are the other causes for the hyperparathyroidism. So in hyperparathyroidism, what will be the manifestation is hypercalcemia, which is very important. What is the normal calcium level? That is 9 to 11 milligrams percentage. That will be the normal calcium levels. And when the calcium levels, when it has reached to a level of 11 to 12 milligrams percentage, right, when the calcium levels have reached 11 to 12 milligrams percentage, the important clinical manifestation or the manifestation will be the renal colic. And this renal colic, it is mainly due to nephrolithiasis, right? And the type of the stones that you will have is the calcium oxalate stones or calcium phosphate stones, okay? And not only that, when the calcium levels are at a level of 11 to 12 milligrams percentage, the calcium, it will accumulate within the gastrointestinal sphincters, causing decrease in the gastrointestinal motility, causing constipation, right, causing constipation. So these will be the features of the hypercalcemia, right? And not only that, when the calcium level have been increased to 11 to 12, it will also stimulate the parietal cells of the stomach and it will produce the HCl, causing pain within the stomach, right, causing pain within the stomach. Okay, so that will be like manifestation when the calcium levels are in between 11 to 12. When the calcium levels are between 13 to 15 milligrams percentage, right? So why the calcium level have been increased up to 13 to 15? That is because of the increased osteoclastic activity and there will be osteoporosis. So these patients, they will have the bone pain, right? They will have the bone pain. And apart from that, they will also have the depression and as well as the psychosis. Right, so there will be depression and as well as psychosis. So that is when the calcium levels are in a range of 13 to 15 milligrams percentage. And when the calcium levels have been like more than 15 milligrams percentage, that will cause the systolic arrest of the individual. Okay, the cause of death will be systolic arrest. Then what will be the bone abnormality? The bone abnormality include the osteitis fibrosa cystica, right? Because the resorbed bone is replaced by the fibrous tissue and that will result in what is called osteitis fibrosa cystica, right? Then you take the spine like they'll have what is called Rugger Jersey spine. Then followed by that, they have the vertebra in a form of the codfish, and this we call it as the codfish spine. And if you take the mineralization of the mandible that is being lost, that we call it as loss of lamina dura. So lamina dura, it is the mineralized portion of the mandible. So there will be loss of the lamina dura. So these are all the bony abnormalities, right? And even if you take the skull, you will notice the presence of the pinhead stippling, right? And why is this pinhead stippling? That is because of the osteoporosis within the skull. So this will be the bone abnormalities, and the cause of death will be the systolic arrest, right? Then coming to the investigations that you observe in the, what are important is, first and foremost, the calcium levels. These patients, they will have the hypercalcemia, then there will be decrease in the phosphorus levels, and there will be increase in the alkaline phosphatase levels, right? And DEXA scan, it is useful for assessment of the bone mineral density. And how is that you will be able to look? And one more point is, because of this hypercalcemia, you will notice that there is short QT interval, right? And how is that you will be able to localize the tumor? The localization of this parathyroid adenoma, that is being done by technetium 99M 𝐶EB scan, right? Technetium 99M 𝐶EB scan. And DEXA scan is useful for assessment of the bone mineral density, wherein you will measure the T score and as well as the Z score, right? T score and as well as the Z score. So T score is that where we compare the bone mineral density of the patient to that of the bone mineral density of a 30-year-old healthy individual. That is T score. Whereas Z score, we compare the bone mineral density of the patient with the bone mineral density of an individual of same age group, healthy individual. That will be the Z score. Then you take the treatment. The treatment of choice in case of the primary hyperparathyroidism. Treatment of choice in case of primary hyperparathyroidism is the surgical resection of the tumor. Then how is that you will manage the calcium levels? So hypercalcemia, this is managed as a first line treatment by giving IV fluids and as well as the furosemide. So IV fluids and as well as the furosemide, this will flush out the calcium, right? And what will be the drug of choice in case of primary hyperparathyroidism causing hypercalcemia? The reason for hypercalcemia in case of primary hyperparathyroidism is like bone resorption. So you need to give a drug that will reduce the bone resorption. What is the drug that will reduce the bone resorption? That will be bisphosphonates, right? That will be bisphosphonates. Okay, so where we give IV ibandronate, right? Where we give IV ibandronate. Okay, and the next important supplementation in these individuals is you need to give the calcitonin nasal spray. So this calcitonin nasal spray, this will reduce the calcium levels. Okay, so this is about the hyperparathyroidism. Now if you take the images related to bony abnormalities, so this will be the osteitis fibrosa cystica, where the normal bone is replaced by the fibrous tissue. Then, so this we describe it as the codfish spine, because if you can see the vertebra, like you have completely scooped out vertebra, right? Then followed by that, this will be the rugger jersey spine, right? Where you have the alternating dark and white over the dark and white pattern over the vertebra. And this is what is nothing but your pinhead stippling, right? And that is because of the osteoporosis, right? And this is the lamina dura that will be lost in case of the hyperparathyroidism. And this we call it as the loss of lamina dura. So where there is loss of the mineralized portion of the mandible, right? So this is about the story related to hyperparathyroidism. And yeah, so this is like the localization. So how is that you will be able to localize? That is the technetium 99M 𝐶EB scan, right? And you can also see the osteolytic lesions within the bone in patients with the hyperparathyroidism, where you have a subperiosteal erosions, right? Next question. Hirsutism is seen in which of the following? Polycystic ovarian syndrome, congenital adrenal hyperplasia, hypothyroidism, ovarian tumor. So Polycystic ovarian syndrome, yes, hirsutism will be there. Congenital adrenal hyperplasia, hirsutism will be there. And ovarian tumor also you will have hirsutism, but not in case of the hypothyroidism. So the correct answer is 1, 2 and as well as 4. Now let me discuss few points about this congenital adrenal hyperplasia. So congenital adrenal hyperplasia, this is caused by mutation in genes encoding steroidogenic enzymes. Okay, so the genes, right, the genes which are encoding the steroidogenic enzymes, they are being defective. And what are these genes that are being defective are, that includes CYP21A2, CYP11B1, CYP17A1, HSD3β2 and as well as POR. So these particular genes, they code for certain enzymes. And what is the use of these enzymes? These enzymes, they are required for the metabolism of the cholesterol into the aldosterone, glucocorticoids and weak sex hormones. Like if you see this, okay, so what you have to remember is that these glucocorticoids, then mineralocorticoids and the weak sex hormones, all of these, all these hormones, they are from the raw material that is cholesterol. And you require a series of enzymes, and these are all those enzymes. And if these enzymes are being defective, the levels of these steroids, they get altered. Like for example, what will be the effect if there is deficiency of 21 alpha hydroxylase? So if there is deficiency of the 21 alpha hydroxylase, that will result in the glucocorticoid deficiency. That will result in the mineralocorticoid deficiency. So the entire cholesterol gets diverted onto the synthesis of the weak sex hormones. So there will be excess of the adrenal androgens. That includes dihydroepiandrosterone acetate and the androstenedione. These two levels are increased. That is when 21 hydroxylase deficiency is there. Then you take 11 beta hydroxylase deficiency. So whenever there is 11 beta hydroxylase deficiency, these patients, they will have glucocorticoid deficiency, and the entire glucocorticoids, they are diverted to increase in the synthesis of the mineralocorticoid, and there will be also increase the adrenal androgen excess, right? So the gene which is being defective is CYP11B1. And if there is defect in CYP17A1, that will result in the glucocorticoid deficiency, right, and the androgen deficiency, but mineralocorticoid excess. So the glucocorticoid synthesis and androgen synthesis is completely diverted onto the mineralocorticoid synthesis, right? Then if there is defect in HSD3β2, in this scenario, you will have similar to that of the 21 alpha hydroxylase deficiency, where in females, if you observe, there will be glucocorticoid deficiency, mineralocorticoid deficiency, and there will be adrenal androgen excess. That is in females, right? Then if there is deficiency or if there is defect in this particular gene, that is POR, that is P450 oxidoreductase deficiency. In this case, these individuals, they will have the glucocorticoid deficiency, right? And they will have the prenatal androgen excess, and there will be, right, prenatal androgen excess, but postnatal androgen deficiency. Okay, so this will be the summary of what I have discussed, right? This will be the congenital adrenal hyperplasia enzymes which are being defective, and in congenital adrenal hyperplasia you will have the hirsutism, right? So that was about the discussion related to hirsutism and congenital adrenal hyperplasia, right? Then coming on to the next question, which one of the following are correct regarding the hypothyroidism? More common in females, autoimmunity is a rare etiopathogenesis. In pregnancy, increased dose of levothyroxine is required. Suppressed TSH is a risk factor for the osteoporosis. So more common in females is right. Autoimmunity is a rare etiopathogenesis is incorrect statement, because Hashimoto's thyroiditis, which is an autoimmune disorder, that is the most common cause of hypothyroidism in India. Pregnancy, increased dose of levothyroxine is required, that is a true statement. And suppressed TSH, this is a risk factor for osteoporosis. That is also a true statement. Okay, so this suppressed TSH, it's a risk factor for osteoporosis. This suppressed TSH can increase the bone resorption. Right, it can increase the bone resorption, and thereby there is high risk of the osteoporosis. Right, thereby there is high risk of the osteoporosis. Right, now if you take this autoimmunity, what is that autoimmunity? The autoimmunity, that will be the Hashimoto's thyroiditis. So Hashimoto's thyroiditis, that is the most common cause of hypothyroidism in India, and this is an autoimmune condition. So thereby it is more common in females rather than males, and it is the condition where you have, because it's an autoimmune disorder, you have lymphocytic infiltration into the gland. Right, lymphocytic infiltration into the gland, and the lymphocytes which have infiltrated into the gland, they produce the antibodies, and these antibodies, they destroy the follicular cells. Right, they destroy the follicular cells. Okay, and once there is destruction of the follicular cells, what will happen to the T3 T4 levels? The T3 T4 levels will be reduced. Right, and even after the destruction of the follicular cells, some existing follicular cells, they are filled with the pink colloid. Right, existing follicular cells, they are filled with the pink colloid, and these follicular cells filled with the pink colloid, they are called as the Əhrdıl cells. Right, they are called as the Əhrdıl cells. Right, and these patients, they have enlargement of the gland, and it is painless enlargement of the gland. Right, so this will be painless enlargement of the gland, and these patients with Hashimoto's very commonly seen in the middle-aged females, and not only the middle-aged females, it is also observed in children from, right, it is also most common in children from non-endemic goiter. And what are the antibodies? The antibodies that you will observe here is thyroid peroxidase antibodies. Right, the antibodies are thyroid peroxidase antibodies. Okay, so this is about the Hashimoto's thyroiditis, which is the most common cause of hypothyroidism in India, which is an autoimmune disorder. Then if you take hypothyroidism, there are multiple other etiologies causing hypothyroidism. We have the iatrogenic causes for hypothyroidism. What is that iatrogenic causes for hypothyroidism? That is supplementation of iodine 131 in the treatment of hyperthyroidism, total or subtotal thyroidectomy, or external irradiation of the neck for lymphoma. These are iatrogenic causes for hypothyroidism. Then we have some drugs that will be causing hypothyroidism, and we have an important anti-arrhythmic drug, that is the amiodarone. Right, and the next important molecule is the para-amino salicylic acid. Then we have the interferon alpha, which are used in the treatment of the viruses. Right, then we have the sunitinib, which is used in the treatment of, right, which is used in the treatment of the renal cell carcinoma. And then the aminoglutamide, once we were using this for the Cushing's syndrome. These are all the drugs that will be causing hypothyroidism. Then we have the congenital hypothyroidism. So congenital hypothyroidism is that, which is the disorder where you have mutation of the TSH receptor. You have the mutation of the TSH receptor on the follicular cells. Right? So once there is a TSH receptor mutation on the follicular cells, the TSH which is coming from the anterior pituitary will not act, and thereby T3 T4 synthesis does not occur. Then we have infiltrative disorder that will be causing the hypothyroidism. Now, what are these infiltrative disorders? The infiltrative disorders, they include amyloidosis. where there is abnormal accumulation of the protein within the follicular cells. Second, hemochromatosis, where there is excessive accumulation of iron within the follicular cells, right? Then sarcoidosis, where there is accumulation of non-caseating granuloma within the follicular cells, right? Then cystinosis, where there is accumulation of cysteine amino acid within the follicular cell. And we have one more important condition called Riedel's thyroiditis, right? Riedel's thyroiditis. So this Riedel's thyroiditis is the scenario where there is excess amount of the fibrous tissue within the gland, and the gland will be stony hard in consistency. Stony hard in consistency. These are all the etiologies that will be causing the hypothyroidism. Then if you take some of the points of differences between hyper and hypothyroidism, the most common cause of hyperthyroidism will be Graves' disease, and this is also an autoimmune disease, and the antibodies are thyroid stimulating immunoglobulins, right? Thyroid stimulating immunoglobulins. And Hashimoto's, this is also an autoimmune disorder where you have lymphocytic infiltration of the gland. And in case of the Hashimoto's, initially they will have what is called hashitoxicosis. Now what do you understand by this term hashitoxicosis? Hashitoxicosis is that where you have the destruction of the follicular cells, there will be release of T3, T4 in excess quantity transiently. So transiently these patients will be having hyperthyroidism. Followed by that, they will have hypothyroidism because the follicular cells are completely destroyed and the reserve is utilized. That is in case of the Hashimoto's. Then if you take the clinical features, these patients with the Graves, they will have heat intolerance, right? And these patients with Graves, they will have weight loss, they will have profuse sweating, right? And these patients with the Graves, they will also have increased appetite. Okay, and exactly opposite in the Hashimoto's, they will have cold intolerance, they will have weight gain, dry skin, and the appetite will be decreased. And if you take the abnormality in the metabolism, there will be increase in the glucose levels, and there will be excessive lipolysis resulting in increase in the free fatty acids, and there will be excessive proteolysis causing proximal myopathy. Whereas if you take in hypothyroidism, the glucose levels will try to be normal because other counter-regulatory hormones will try to maintain the glucose, but these patients, they are at increased risk of dyslipidemias because the lipolysis does not occur. Thereby they will have increase in the triglycerides, increase in cholesterol, increase in LDL, increase in VLDL, and there is also decrease in HDL. So thereby they will have dyslipidemias which can cause atherosclerosis, right? Then followed by that, in case of Graves, if you take the cardiovascular system metabolism or cardiovascular system features, there will be hypertension, there will be tachycardia, and these patients, they are at increased risk of the arrhythmias, and very common is the atrial fibrillation, and finally there can be development of the heart failure as well. And they will also have a murmur, mid-systolic murmur, because of increased cardiac activity. Whereas in Hashimoto's, they will have hypertension, but that will be diastolic hypertension, and there will be also development of the pericardial effusion, right? And the next important in case of the Hashimoto's is there will be bradyarrhythmias, that is the AV blocks are very common, right? AV blocks, they are very common, right? Then you take the respiratory and gastrointestinal involvement. In Graves, there will be tachypnea, and the gastrointestinal, they'll have diarrhea. Whereas in hypothyroidism, there will be decrease in respiratory rate causing type 2 respiratory failure, and these patients, they'll have constipation. And if you take the CNS manifestations and as well as the sleep of the individual, CNS, they will have anxiety, right? And they will have tremors, right? Anxiety and as well as tremors. And there will be decreased sleep because of the anxiety neurosis. Whereas in case of the Hashimoto's, that is hypothyroidism, these patients, they are dull and lethargic and they will be having excessive sleep. And one of the very important reliable sign is the reflex, and that we call it as the hung up reflex, right? And in this hung up reflex, there will be delayed relaxation of the deep tendon reflexes. That is what is called the hung up reflex. Whereas in case of Graves, there will be increase in the deep tendon reflexes. Brisk reflexes will be there. And you have two important terminologies, that is Jod-Basedow and as well as Wolff-Chaikoff. So in case of Jod-Basedow, what exactly is this? It is in an individual with a goiter, right? In an individual with a goiter, when you give an exogenous iodine, if there is iodine-induced hyperthyroidism, iodine-induced hyperthyroidism, that is Jod-Basedow's phenomena. Whereas iodine-induced hypothyroidism, right? So this will be the Wolff-Chaikoff effect, okay? And this Wolff-Chaikoff effect is due to transient inhibition of the organification, right? So this is due to transient inhibition of the organification. So that is about the Hashimoto's thyroiditis and the Graves' disease, right? Now, after having discussed about the differences between the hypo and as well as hyper, one important is the skin, okay? The difference in the skin. If you take the hyperthyroidism, they will have a waxy skin over the shin of the tibia, and that we call it as the pretibial myxedema. So pretibial myxedema is that where you have the presence of the waxy skin over the shin of the tibia. Whereas you take in case of the hypothyroidism, they will have the yellow skin. And why is that they have this yellow skin? That is because of the carotenemia. That is because of increase in the beta carotene levels in patients with the hypothyroidism. And one important sign that you need to remember is Pemberton sign. This Pemberton sign, it is observed in patients with the retrosternal goiter. So in patients with retrosternal goiter, what can happen is this goiter, and these individuals upon raising the arms, right, these individuals upon raising the arms, right, there will be facial congestion, right, there will be facial congestion. And this Pemberton sign, this can be evaluated by the CT or the MRI, right? That can be evaluated by the CT or the MRI, okay? That is, your retrosternal goiter can be visualized by the CT or MRI of the chest. So these are some important points related to the thyroid, right? Whereas the workup and as well as the treatment, I will discuss that in the subsequent questions, okay? Next question. Which of the following are correct regarding the diabetes insipidus? Polyuria and polydipsia are the common symptoms. Urine is of low osmolality and the specific gravity. Lithium is useful in the treatment. It is potentially lethal if hypothalamic thirst center is damaged. Select the correct answer using the code given below. So polyuria and polydipsia, they are the common symptoms in diabetes insipidus, is a correct statement. And urine osmolality is low and specific gravity is also low, correct statement. Lithium is useful in the treatment is a wrong statement. And it is potentially lethal if the hypothalamic center is damaged in case of the diabetes insipidus, that is also a true statement. So the correct point is what now? That is 1, 2 and as well as the 4. 1, 2 and as well as 4. Okay. Now let me take up the discussion of the diabetes insipidus. It is a disorder where you have decrease in the levels of the antidiuretic hormone, or there is resistance to the action of the antidiuretic hormone. Right, there is resistance to the action of the antidiuretic hormone. Now we have two forms of diabetes insipidus. Central diabetes insipidus is that where there is decrease in the ADH levels. Nephrogenic diabetes insipidus is that where there is resistance to the antidiuretic hormone, right? And what will be the clinical features in these patients with diabetes insipidus is there will be, or they will have, the polyuria and as well as the polydipsia. So polyuria is that where the urine output will be more than 3 liters per 24 hours, right? Or that will be more than or equal to 50 ml, right, more than or equal to 50 ml per kg in 24 hours. So that will be the urine output in case of the diabetes insipidus, right? And what is the investigations? If you observe, the urine osmolality will be reduced, the serum osmolality will be decreased, right? And the serum sodium will be increased. Then what is the investigation of choice? Investigation of choice will be the water deprivation test. The investigation of choice will be the water deprivation test. Okay. Then what is the treatment? So the treatment, and what is the use of this water deprivation test? The use of this water deprivation test is that it will be helpful in differentiating central and nephrogenic diabetes insipidus from psychogenic polydipsia as well. And the drug of choice for central diabetes insipidus is desmopressin. And this desmopressin, whatever we are giving, it is given via the subcutaneous route, the intravenous route, inhalational route, and even the oral formulation. And why is that we give desmopressin over the vasopressin is that desmopressin, it has a long T-half, right, long half-life, and it has the selective V2 receptor action. Whereas nephrogenic diabetes insipidus, the drug of choice is the thiazide diuretics. Okay, and these thiazide diuretics include the hydrochlorothiazide, right? And for lithium-induced diabetes insipidus, amiloride is considered as the drug of choice, right? Amiloride is considered as the drug of choice for lithium-induced diabetes insipidus. And what exactly is your amiloride? It is an ENaC blocker, epithelial sodium channel blocker. Then what exactly is the differential diagnosis for diabetes insipidus? That will be psychogenic polydipsia. So in psychogenic polydipsia, so how is that you will be able to differentiate psychogenic polydipsia from diabetes insipidus? Because these patients also have polyuria polydipsia. In these patients, the serum osmolality is reduced and even the urine osmolality also will be reduced. That is what you will observe in case of the psychogenic polydipsia. Then you take 3 different clinical scenarios. A patient presented with the polyuria and as well as polydipsia, and urine and as well as the serum osmolality parameters are given here, right? So you take the first patient. Serum osmolality is increased, urine osmolality is decreased. Where do you have that? In patients with the diabetes insipidus. And you take the second scenario. In second scenario, both are reduced. Urine osmolality, serum osmolality, both of them are decreased, right? That you see in psychogenic polydipsia, right? That you observe in psychogenic polydipsia. And you take the third, that is the serum osmolality will remain normal or increased, and at the same time the urine osmolality is increased. You see that in diabetes mellitus. Why is that the urine osmolality is increased? That is because within the urine you have the excess amount of the glucose in diabetic patients. So there is glucosuria. So that is the reason why in diabetes mellitus the urine osmolality is increased. Okay, so this is about like the patients presenting with the polyuria and polydipsia and in these 3 different scenarios, right? Then followed by that, yes, you see the evaluation of the thyroid. We have a 42-year-old lady present with symptoms of tiredness, constipation, impaired hearing and weight gain in spite of the poor appetite. Which of the following are the relevant investigations? So tiredness, constipation, impaired hearing and weight gain in spite of the poor appetite. So all these points are suggestive of the hypothyroidism. Okay, now what are the relevant investigations? TSH, yes, it is important. Free T4, yes, that is also very, very important. Then anti-TPO antibodies in Hashimoto's, what did we discuss just now? Yes, it is anti-TPO antibodies which are thyroid peroxidase antibodies which are important in hypothyroidism. And radionuclide scan for the thyroid, like it is question mark. In some cases of hypothyroidism it is required and in some cases it is not required. So the best answer would be what? That is 1, 2 and as well as 3. Now if you take the workup, that is the investigations in patients. Okay, now before going on to the detailed investigations, these thyroid related disorders, we classify them as the following, that is the individuals with the primary hypothyroidism, then secondary hypothyroidism, then primary hyperthyroidism, then we have secondary hyperthyroidism. So accordingly, you see T3, T4 and as well as the TSH. So in primary hypothyroidism, the problem is within the gland, T3, T4 levels will be reduced and TSH will be increased because there will be inhibition of negative feedback mechanism over the anterior pituitary. Secondary hypothyroidism, the problem is in the anterior pituitary, so TSH is reduced. So in respect to that, T3, T4 also will be reduced. And in primary hyperthyroidism, the problem is in the gland, so T3, T4 levels are increased, and this increased T3, T4 will inhibit the anterior pituitary, thereby the TSH will be reduced. Whereas in secondary hyperthyroidism, where the problem is in the anterior pituitary, the TSH levels are elevated. In respect to that, the T3, T4 levels are also elevated. So in secondary hypothyroidism, everything is decreased, and in secondary hyperthyroidism, everything is increased. So this is how, so the TSH is very important in evaluating the thyroid related disorders. Either you take primary or secondary hyperthyroidism. Then apart from the T3, T4 and TSH, and again within the T3, T4, TSH also, what is very important is this free T4 levels, right? After the evaluation of the TSH, the next important parameter that you need to check for is free T4. Why? Because majority of the hormone which is released from the follicular cell is T4, and this T4 will undergo deiodinization where it is being converted into T3, right? So T4 is converted into T. So FT4 is very, very important part of the evaluation. Then you take the radioactive iodine uptake studies. Like, what is the radioactive iodine that we take into consideration is, that is iodine 123 or we take iodine 132. Iodine 123 or iodine 132. Okay, so you need to know in which condition you have increased radioactive iodine uptake and in which condition there will be decreased radioactive iodine uptake. Increased radioactive iodine uptake, it is observed in Graves and the toxic nodule. Decreased radioactive iodine uptake, it is observed in subacute thyroiditis, which is nothing but the 𝗑𝐿 thyroiditis, which is characterized by the hypothyroidism, right? And it is also observed in case of the lymphocytic thyroiditis, right? And also seen in case of the postpartum thyroiditis, right? Postpartum thyroiditis. So this is about radioactive iodine uptake studies. Then you take the treatment. In case of hyperthyroidism, the drug of choice will be methimazole. Okay, so why is that we give methimazole, right, which is a thyroid peroxidase inhibitor? Because methimazole, it has a long half-life, right? That is the reason why we give methimazole. And whereas in first trimester of pregnancy, we give propylthiouracil. We don't give methimazole. Why? Because methimazole is associated with the teratogenicity, and the teratogenicity of methimazole is the aplasia cutis. Right, the teratogenicity of methimazole is aplasia cutis, right? And this propylthiouracil, this is not teratogenic, right? This is not teratogenic. That is the reason why we give propylthiouracil in the first trimester, whereas in second and third trimester, we give back again the methimazole. Why? Because in second and third trimester, the organogenesis is over, and this particular methimazole, it is not teratogenic in second and third trimester, and it has a long half-life. And not only that, this propylthiouracil is associated with very severe hepatic fibrosis, and that is the reason why we give propylthiouracil only in the first trimester and stop in second and third trimester. And the other drugs which are required for hyperthyroidism is propranolol, that is beta blocker. That is why, for reducing the anxiety, for reducing the tremors, this will also reduce the conversion of T4 to T3. That is the reason why we give propranolol, right? Then next to this beta blocker, that is propranolol, the other way by which you can treat is by supplementing iodine 131, which will release the beta rays and will destroy the follicular cells. and the other way by which you can treat is by doing the thyroid surgery. Right, by doing the thyroid surgery. Okay. Then coming to the treatment in the hypothyroidism. So if you see the treatment in the hypothyroidism, we give levothyroxine, right? And this particular levothyroxine, it is T4. Okay, and the dosage of levothyroxine is 1.6 microgram per kg per day. And this levothyroxine, it should be given early morning fasting state. Right, early morning fasting state. So why is that we give early morning fasting state? Because the food, it will inhibit the absorption of the thyroxine. So that is the reason why we give it an early morning fasting state. And not only that, in those individuals with cardiovascular abnormality, you need to start with low dose. For example, if the patient is having underlying coronary artery disease, you need to start low dose of the levothyroxine. When you start low dose of levothyroxine, the advantage is that the cardiac demand will not increase, because levothyroxine will increase the heart rate. When you give full dose, it will increase the heart rate, it will increase the myocardial oxygen demand, right? But the supply will be less because of the underlying coronary artery disease. So that is the reason why don't give full dose in individual with coronary artery disease. You start with low dose and gradually step up the dose. Those individuals not having any cardiovascular disease, you can give full dose of up to like 1.6 micrograms per kg per day. That can be given early morning fasting state, right? And this is the flowchart of how you need to evaluate the thyroid related disorders. First and foremost, very important is measure the TSH. Then followed by that, the next important is you need to measure the unbound T4. So based on these two parameters, we will be able to make out whether it is hypo or hyperthyroidism, and accordingly you need to work up for the underlying etiology. So this is about the workup and as well as the treatment of the thyroid related disorders.